All right. I think it's so important to have people to talk about their experiences and not just keep it to research and data and and our professional hats, but we all have clinical hats too, and some of us do, and some of us in different capacities have personal experiences. So this is just one case that I've seen in my clinical practice at the Jewish General Hospital. I'm a psychologist, yeah, I thought could illustrate the complexities of and challenges of having to deal with suffering and what's behind a MAiD request. So my patient was 77 years old. I mean, that I've changed some data about the patient so that they're not recognizable. It was a man, and the chief concern of the patient was that he wanted to die, and he requested MAiD. So this is a person that was diagnosed with non-Hodgkin lymphoma. He received a chimeric antigen receptor T-cell therapy. He became immunocompromised, and he developed an infection. So he needed to be hospitalized in the ICU. And in the ICU, he had a myocardial infarction. So, this is a gentleman that was, baseline, from the start before his diagnosis, very active. He walked a lot. He was, had an active profession. And at the time of my involvement, his state had stabilized, and he was transferred from the ICU to the hospital unit. So his functional mobility had declined considerably. He was at that point when I saw him completely disabled. He couldn't carry on any self-care. He was hospitalized, totally confined to his bed or chair. He wasn't eating. He wasn't sleeping well, and he was in really bad shape, physically and emotionally. I was brought to consult on him, and I was told from the start that this guy is very abrupt. He's, very abrasive, very aggressive. He rolls his eyes. He's kind of, has this immaturity to him in his behavior, and he is refusing his medication. In terms of his social and family situation, he was working as a blue collar. He was never married. He came from a large family, and he was raised on a farm. He had a girlfriend of a few years at the time, and he was, again, healthy, active lifestyle, no medical comorbidities, no medication, when I saw him, he was very weak. He had lost a lot of muscle mass, but he was oriented to person, place, context, and date. He had good short-term memory, except for a small part during his hospitalization when he had a urinary infection. He was uncooperative. He avoided eye contact. It was difficult to engage. He was passive. He was hostile. He expressed nonverbal signs of frustration with me, rolling his eyes, turning away, closing his eyes. He had flat affect. This was someone that was very difficult to engage with, very difficult, and actually very easy to disengage from. It's not someone that's very pleasant to work with necessarily. So I think he kind of actively engaged in disengagement, and people became disengaged around him too. So in terms of, if we look at the Edmonton symptom assessment system, pain was high, fatigue as well, and nausea was low, depression and anxiety, he scored 10. Drowsiness, shortness of breath wasn't an issue, appetite was an issue, and sleep was an issue. So the impact of the cancer diagnosis on the patient and the family, well, so the patient, I came to know, felt very abandoned by his family. He felt that no one cared about him. He refused to contact them because he thought that they should initiate since he was in the hospital. that they should be the one that come to his bedside, and he didn't receive enough visitors. They did live far, so they, this is was in Montreal, the hospital, and so they lived in, maybe 40 minutes, an hour distance. So it was difficult for them to travel, but he was expecting much more contacts, and he felt very injured. In terms of his past or current medical consultation, there was no prior mental health consultation, but clearly there was some trauma that was revealed. Actually, he had told one of his nurses that he was severely beaten as a child, and then because we were communicating also, I came to know of this and then was able to address it with him. His father beat him with a crowbar on certain occasions, and this went on for several years until he stood up for himself. He had what seems to be ADHD, and irritability was in the family, in the father, and he was also handicapped by an accident at some point in his life, not related to the father, but related to some situation on the farm. And so that also contributed to some issues with his self-esteem and body image. So in terms of access to healthcare, he was very sensitive to staff change over the weekend because he had, he felt abandoned over the weekend. Bedside manners of staff. So if anyone came in and didn't say hello, how are you? He felt injured. He felt rejected. It was very difficult for him. He's very sensitive. And, so some of the cleaning people would come in and they would clean, and, they would just come in to clean, and they wouldn't acknowledge him. Then that was a source of a lot of frustration and suffering. And he didn't ask for pain medication. So those were very important issues that underlined his requests for MAiD. So now, to the patient, in terms of the goals of care, there were different goals of care with this patient. I saw him twice a week on the hospital unit, and at first, for him, it was important. Affection and connection were important, and you may never know that was the case, considering how aggressive and very abrasive he was. But he was also very distressed from his trauma. So he had very intrusive thoughts about his abuse, and it was very difficult for him. And that's something that prevented him from sleeping at night. So the first task for me was to engage with the patient. So alliance building was very important. And then to kind of, with this alliance, work towards behavioral activation and rehabilitation goals. Of course, I was treading difficult waters because I didn't know if he would, is it possible for this person to improve, or will he actually, just stay incapacitated? And, how does that play out, the physical state in his MAiD request, and what's reasonable to think as in terms of objectives. So we had to work in a multidisciplinary way with the physiotherapists and the physicians towards rehabilitative goals, and towards his mindset also. Understanding, I understood his MAiD request was a function of suicidal ideation, hopelessness, helplessness, despair tied to his feeling of being abandoned, his trauma symptoms, his loss of function, dependency, and to a lesser extent, but still body image. So body image was very important to him because this was a man who was autonomous, he was living at home, he was independent, and all of a sudden he became dependent. And so this activated all kinds of issues that he had from all of his abuse and trauma past, and all of his disruptions in terms of his attachment to caregivers. And this happens a lot, when people have adversity early in childhood, or where it gets recreated, especially when people become more dependent and they're hospitalized, or they lose function, and then they have to depend on other people. So I helped him with communication and social skills training to become more proactive rather than passive aggressive, to ask for pain medication when he needed it, used trauma-focused therapy to help, with the trauma, and consultation liaison psychiatry also to address, his issues around anxiety, demoralization, and trauma. We had family meetings to clarify the anger and dismissal and the underlying need for affection, attention, and the feelings of being abandoned. There were team meetings also to talk about sensitivity to interactions and lack of interactions, and how, he was particularly sensitive to staff turnover and to bedside manners. And boundaries in the therapeutic relationship were also important because at some point he thought that it was either that he had an affectionate tie to me or his girlfriend. So I had to clarify that wasn't the case. Actually, my role was X in a box, and I was working towards enhancing his connections to other people, because at some point he actually cut his ties to certain people. So the medical team assessed for MAiD, and it wasn't exactly integrated. They came in kind of, and I was here and they were there and they did their own thing. And they were, then at some point, we met as they were exiting the room, and I asked them, well, if the patient was found to be eligible, and they said, yes. He's eligible. And I thought, oh my God, okay. I'm working really very hard with him on all of these objectives. And I wasn't even sure actually, and it was very difficult, painful for me because I didn't know if he would actually be alive when I came back to see him the next time. And I had to also, once, kind of defer to my medical colleagues about the prognosis and the medical team and physiotherapy, but I also had to debate that this was, in my opinion, suicidal ideation, demoralization, trauma, and so it was a challenge. It was a bit stressful. So as an outcome, he eventually did not receive MAiD. His family and girlfriend relationships improved, and there needed to be a lot of interventions for that to happen. I mean, it wasn't ideal because, of course, he's still was complex in his approach, but at least there was an understanding of the suffering behind that. He was engaged eventually with a lot of cheerleading in rehabilitation goals, and he progressively regained strength. And he was discharged into a rehabilitation center, and he eventually returned home. So for the team, it was kind of a bit surprising because from someone that was in the dumps, really not doing well, nowhere to go, and no hope, right? And all of a sudden, he, we helped him turn around, get better. He was able to walk. He was able to, and so when he visited the clinic, he said that he was grateful to be alive, which to me is that's the rewarding part, I guess. Not without challenges, I'm sure, but that's